diuretics. Okay, so there are basically 5 types of diuretics which you need to understand. So number one type of diuretics is equal carbonic anhydrous inhibitors. So number one type of carbonic anhydrous inhibitors. So where these carbonic anhydrous inhibitors act, they act basically on the proximal tubule. They act on proximal tubule, right? So you need to know that in the proximal tubule there is sodium. Normally in the proximal tubule there is sodium reabsorption, okay, with exchange of hydrogen ions. Okay, so we call this a sodium hydrogen exchange. Sodium hydrogen exchange. Okay, so let's see what happens here. So let's say this is, okay, so this is the lumen, and this is the okay, so fluid is moving from here, right? So here what happens, this is the apical border. Okay, if you see the cells here, the cells are this is the transitional epithelium lying in the tubes. So the border of the cell that is towards the lumen we call apical border, and here is the blood vessel, and the back side is called basolateral membrane. So this side is called basolateral membrane, this side is called apical membrane. Okay, so apical membrane is towards the lumen, towards the fluid. Okay, so this is called apical membrane, and this side is called, back side is called basolateral membrane, and this is the blood vessel where they will be reabsorbed. So what happens in proximal tubule? Okay, you can always interrupt me if you don't understand. Listen. So what happens in proximal tubule? There is here formation of hydrogen ion plus bicarbonate. Okay, and forms H2CO3. We know that this is H2O plus CO2. Okay, so this thing is formed here. This reaction takes place in both ways, and the enzyme responsible for this reaction is carbonic anhydrase. Carbonic anhydrase. Okay, so in the proximal tubule, you know that 65% of the water is reabsorbed. 65% of water is reabsorbed along with sodium ions. So you have to understand this fact that when sodium is absorbed, it also drags water along with it. So if you can block the sodium ion absorption, then you can also block the water absorption. As a result, urine output will be more. That is the main motive of diuretics. So diuretics will basically stop the sodium reabsorption. So if we can block the reabsorption of sodium ions, water reabsorption will be also stopped, because sodium and water, they go together, and as a result urine output will be more. So if we stop the sodium absorption, so sodium will be more lost in the urine, as a result water will be more lost in the urine output will be more. That is the main role of the purpose of diuretics. So what happens here, this carbonic anhydrase, this enzyme, it controls this reaction, water plus carbon dioxide forming of carbonic acid, then forming bicarbonate. Okay. So water plus carbon dioxide is forming carbonic acid, then it is splitting into bicarbonate and hydrogen ion. So in the late part here, most of the bicarbonate ion which is formed here, okay, we see in this part. Okay, so we see in a reversible way. So water plus carbon dioxide forming bicarbonate, which is splitting into carbonic acid, which is splitting into bicarbonate and hydrogen ions. Okay, this is a reversible reaction. So what happens, this bicarbonate is absorbed along with sodium. So here most of the bicarbonate is reabsorbed. So here is the blood vessel. Okay, most of the bicarbonate is reabsorbed with sodium. In the first part of the proximal tubule, especially in the convoluted and the first part, usually sodium is directly reabsorbed, okay, directly reabsorbed to the surrounding blood vessels. But in the late part of the proximal tubule, sodium is absorbed along with the bicarbonate, sodium plus bicarbonate. So the thing is that if we can block this enzyme, that no bicarbonate is formed, then sodium will not be absorbed. So if sodium will not be absorbed, water cannot be absorbed. Water cannot be absorbed in this late part. So it works only in this part. That's why this diuretic is also the weakest diuretic. Okay. So most common carbonic anhydrase inhibitors are acetazolamide. And they are typically used in where there is small pocket collection of fluid. Basically, they are used in glaucoma. Acetazolamide is used in glaucoma. So acetazolamide is one type of diuretic which are carbonic anhydrase inhibitors. Now carbonic anhydrase it controls this reaction and as a result there is formation of bicarbonate. So when bicarbonate, so here what happens in the tubes, inside the tubes, okay, let me make it more clear. Inside the tubes, once the bicarbonate is formed, so this is the lumen, okay. So bicarbonate is formed, it will combine with sodium, that will form sodium bicarbonate, and then it will be absorbed. So we are stopping the formation of bicarbonate. As a result, this amount of sodium here, only in this part, because in the upper part sodium reabsorption takes place independently, it don't need bicarbonate. But in the lower part of the proximal tubule, sodium combines with bicarbonate and it is reabsorbed. Okay, so if we don't allow there is any formation of bicarbonate, sodium cannot be reabsorbed. So as a result, sodium will pass in the urine. So sodium is an osmotic particle, it will drag water molecules. Along with it, and water will be lost in the urine. As a result, urine volume will be increased. That is one type of diuretic. Is that clear? Or anyone wants me to repeat?
Sir, can you repeat?
Yeah, please tell me when you don't understand, okay? There's no problem in repeating, okay? You should. Okay, let me take this portion of the proximal tubule here. Okay, this is the proximal tubule, and these are the cells. So here what happens? So this is called apical border. This is called basolateral border. So here usually what happens here? Water combines with carbon dioxide and forms hydrogen ion and bicarbonate. Okay, it forms hydrogen ion and bicarbonate. This bicarbonate combines with sodium and forms sodium bicarbonate. This sodium bicarbonate, it is reabsorbed here. Normally, it is reabsorbed to this surrounding blood vessels, especially in this later part of proximal tubule. So this sodium bicarbonate is reabsorbed. Now if we block this reaction, as a result, no bicarbonate is formed. So sodium, this amount of sodium which can be absorbed only by combining it with bicarbonate, it cannot be absorbed because some amount of sodium in the proximal tubules is reabsorbed only along with bicarbonate. Okay, so we are reducing the amount of bicarbonate in this late part of proximal tubule. Most of the sodium is here already absorbed. When it coming from here, most of the sodium ions are already absorbed. In the late part, whatever sodium ions are available, they combine quickly with bicarbonate available there and form sodium bicarbonate and easily reabsorbed to the blood vessels, right? Easily reabsorbed to the blood vessels. So now we are giving acetazolamide, which is a carbonic anhydrase inhibitors. So when we block this carbonic anhydrase, which is mediating this reaction, as a result, this reaction will not take place. As a result, no bicarbonate can be formed. As a result, no sodium bicarbonate will be formed. As a result, sodium bicarbonate will be excreted. Now, as sodium will go more and more, it will also take water along with it. As a result, urine volume will be increased. So that is one role of diuretic. That is one type of diuretic which acts by inhibiting carbonic anhydrase enzyme. Okay, so it is called as carbonic anhydrase inhibitor. Best example is acetazolamide, which is mostly used in any sort of glaucoma. in glaucoma, when the patient complains of eye pain, headaches, we give acetazolamide. Okay, it is the weakest diuretic because only a little bit of sodium is reabsorbed here. Okay, in this part, because 65% of sodium is reabsorbed here. Out of 65, you can say only 1% of sodium is left here to be absorbed. Most of the sodiums are already absorbed. So it can only increase the urine volume a little bit. So it can reduce the edema little bit, you can say. And so we basically use it for glaucoma conditions when there is an extra amount of fluid collected in the eyeball, causing headache and swelling of the eyeball. Okay? Is it okay?
Yes, sir. Thank you.
Okay. Okay, we move to the next now. So that is one type of diuretic we use. That is carbonic anhydrase. So next type of is coming to the now thick ascending limb. Okay. Now let's come to the thick ascending limb. What happens? So let me make a thick ascending limb here. And these are the epithelial cells. Okay. So in thick ascending limb, there is absorption of sodium to chloride and potassium together. Sodium to potassium and chloride, they are absorbed quickly. They are co-transport. Okay, when sodium is absorbed, chloride and potassium are go along with sodium. They are okay together. It's a combo in the thick ascending limb. Remember, this thick ascending limb is impermeable to water. So here, this is the lumen. Okay, so fluid is going up. So the sodium, chloride and potassium, they quickly move from into the apical side of the cell. And from here, this sodium moves out with the sodium potassium pump. With the help of sodium potassium pump, it goes to the surrounding blood vessels. And though this potassium goes, again it is recycled. And this potassium will again come back. So this side is called basolateral membrane. Okay. So it just try to understand it. Okay. You don't need to go in so much of detail. Just try to understand that here, in this thick ascending limb, 1 sodium, 2 chloride, potassium ions are reabsorbed. So the drug here are, so second type of diuretics, they mostly we call loop diuretics. So the second part of diuretics are called loop diuretics. So what these loop diuretics do, they block this sodium, chloride, potassium reabsorption. So when we are blocking this channel, the sodium 2 chloride potassium channels, so as a result what will happen now? The urine will lose sodium, urine will lose chloride, urine will lose lots of potassium. And we know sodium is the osmotic particle. As more sodium will pass into the urine, more fluid will pass into the urine. So urine volume will be increased. So sodium is the osmotic particle. So when we are increasing the sodium output in the urine volume will automatically increase. So the loop diuretics, where they act on the thick ascending limb. This is the most common type of diuretics that is used clinically. The best example is Lasix. So Lasix is a commercial name. I give you the original name. We call it furosemide. Okay, furosemide. Furosemide, bumetamide, ethacrenic acid. Okay, so these are the examples of loop diuretics. So loop diuretics, for example, furosemide and bumetan, and how they act, they block this sodium 2 chloride potassium ions. Moreover, here in these thick ascending limbs, not only sodium, chloride, potassium are reabsorbed, there is also reabsorption of calcium, and magnesium. Calcium and magnesium. That's why the main side effect. Now, if you understand this thing, then in the exam, when you go to year 2, year 3, year 5, year 6, so when your examiner will ask you what are the side effects, very common question, you will get MCQs or Viva. What are the side effects of furosemide, or what are the side effects of loop diuretics? Now, what are the side effects? You see, now when we use these diuretics, this diuretics is most commonly used for hypertension when the blood pressure is high, and to prevent heart failure, ascites. It is used everywhere. The most common side, look, when we are giving loop diuretics, it is blocking the absorption of sodium to chloride potassium. So what will be the composition of urine here? So urine will lose sodium, urine will lose, with urine there will be chloride, with urine there will be potassium, with urine there will be magnesium, with urine there will be calcium. So the known side effects are, okay, forget sodium because we have plenty of sodium inside. So what are the side effects? There will be hypokalemia, low potassium amount in the body. Low potassium is very, very serious complication. Okay, normal level of potassium is 4 to 5, 4.5, 5.5 like that. It's in the range of 5 milliequivalent. But when the potassium level goes down, it stimulates it. There is an effect on the heart and many other things. Okay, so hypokalemia is one common side effect of loop diuretics, along with hypocalcemia, hypomagnesemia. Means all these electrolytes are lost in the urine. You see that here not only sodium is reabsorbed. When sodium is absorbed, it drags chloride, it drags potassium, and also it creates a potential gradient that magnesium and also calcium they also follows. So if you block this channel, you are blocking all this reabsorption of the nutrients, electrolytes. So as a result, these electrolytes are lost in the urine. Okay, so that is one common side effect of loop diuretics or furosemide or bumetanide. Okay, hypokalemia. So here we are losing lots and lots of potassium. As a result, potassium amount in the blood goes down. We call it hypokalemia. That is also very big complications. So when you give furosemide diuretic, we are using it for swelling, ascites or whatever it is. We regularly check the potassium level in the blood, whether it is going down. If it goes down, you have to replace it or you have to stop. Now coming to the distal tubule. So in the distal tubule, sodium and chloride. Sorry, this opposite direction. Okay, sodium and chloride are reabsorbed. So in the distal tubule, sodium and chloride are reabsorbed. Okay, in the distal tubule. So distal tubule, sodium and chloride are reabsorbed. So here, the number 3 type of diuretics is called thiazide group of diuretics. This is also very commonly used in hypertension. Thiazide group of diuretics, like chlorothiazide. Okay, thiazide group of diuretics. So these diuretics stop this sodium chloride channel, and as a result, sodium and chloride could not be absorbed. As a result, sodium chloride pass in the urine. Okay, and remember, when sodium, most of these diuretics they cause hypokalemia because along with sodium, potassium also most of the time pass through the urine. So the thiazide group of diuretics, where they act, the question for year ones, where they act on distal tubule. Okay, they act on distal tubule. Where the loop diuretics act, they act on the thick ascending limb. Where the number 1, that is carbonic anhydrous diuretics act, they act on proximal tubule. Simply for the MCQs. Now coming to the cortical duct. So this is the cortical duct. In the cortical duct, there are 2 types of cells. Okay. There are 2 types of cells. One type of is principal cells. Another type is called intercalated cells. So in the collecting duct, this is called principal cell. Wait. Principal cells, and the other is called intercalated cells. Intercalated cells. Okay. In both these principal cells, and there are 2 varieties of cells in collecting duct. So in both these principal cells and intercalated cells, what is the mechanism of sodium chloride, sodium absorption here? Normally, so sodium is here, it is reabsorbed and potassium is secreted. So there is a sodium potassium exchange mechanism. Sodium is absorbed with potassium exchange. So one molecule of sodium is absorbed, one molecule of potassium is secreted in the fluid. Okay, one molecule of potassium is secreted in the fluid. So here Another group of diuretics, that is now fourth, I think, yes, fourth group of diuretics. They are potassium-sparing diuretics. Sparing diuretics. Now, why they are called potassium-sparing, I'll tell you. So these diuretics, the next group of diuretics, number 4, where they act on this channel. They act on this channel. So they block this channel. So as a result, what happens now? You are blocking the absorption of sodium. So if sodium is not reabsorbed, potassium will not be secreted. So this is the only diuretic that prevents the loss of potassium in the body. So whenever we see the potassium level in the body going down because of this loop diuretics, we immediately come to this number 4 diuretics, where potassium is not lost in the urine. It is not secreted, because if you block the absorption of sodium, potassium cannot be reabsorbed here, right? So this type of diuretics, which are potassium-sparing diuretics, they are mostly amyloride, triamterene. So these are the fourth group of diuretics which are blocking the sodium-potassium exchange mechanism. As a result, sodium cannot be absorbed. As a result, potassium cannot be secreted. So yes, it has increased the sodium load in the urine. So urine output is increased. Plus, it has also saved the potassium to be lost in the urine. So potassium is also not lost in the urine. So this is the diuretic that is. Yes, you have any questions? You can switch on your mic and tell me. Talk to me. Yeah. Okay, don't raise your hand. You raise your voice. Yeah. Yeah.
In loop diuretics, sodium-potassium pump is inhibited, right?
No. Sodium-potassium pump is on the basal side. In the loop, there is loop diuretic. This part in the apical side, this whole channel is inhibited. Sodium 2-chloride potassium. Okay, I just told you here how it is absorbed in the other side. Okay, this channel is activated. So when this channel is blocked, so all these things are lost in the urine. Simple. Okay.
Thank you, sir.
So in the collecting duct, sodium is absorbed normally with exchange of potassium ions. So once sodium is absorbed into the blood, one potassium comes out of the blood. Okay, so we are blocking this exchange mechanism here by amyloride or triamterene. So as a result, sodium is not absorbed, so potassium is not coming out, because this is an exchange mechanism, that sodium is absorbed here only by exchange mechanism, give and take. So if you don't allow sodium to go into the blood, potassium also will not come out of the blood. So blood is preserving the potassium when you give this type of antibiotics. Okay, so it is the only drug that prevents hypokalemia. But what is the side effect? If examiner asks you what is the side effect of amyloride, it can cause, long term can cause hyperkalemia. Long term can cause hyperkalemia, because potassium content in the blood may increase because it's not going in the urine. And if so, sometimes we give amyloride and then we do a ECG. In the ECG, we can find tall T waves, which says that there is hyperkalemia when there is tall T waves in the ECG. So with amyloride, you need to monitor the heart rate. You need to see the ECG also time to time. So this is the basic thing, right? Another group of diuretics that is also coming in the fourth group is called aldosterone inhibitors. Aldosterone inhibitors. Now, if you remember from the RAS system, renin, angiotensin, aldosterone system, what does aldosterone do? Aldosterone here in the principal and intercalated cells, they increase the absorption of sodium. So when the aldosterone is released by the adrenal gland, adrenal cortex, they increase the sodium and water reabsorption. They increase the sodium and water reabsorption. Now, if we just block the aldosterone hormone, then also plenty of sodium and water will be preserved. It will not be reabsorbed and it will go into the tubes. Okay. So most common aldosterone inhibitor is spironolactone. So spironolactone is an aldosterone inhibitor and it is also a potassium-sparing diuretics. So under potassium-sparing diuretic, there are two types. One that inhibits the principal cells. In the principal cells, it inhibits the sodium-potassium exchange mechanism. And another group of potassium-sparing diuretics are directly aldosterone inhibitors. They inhibit the aldosterone hormone. As a result, this aldosterone effect in the collecting duct is lost. So some of the sodium will not be absorbed. So some of the water will not be absorbed and urine volume will be increased just a little bit. Okay, this is also not so efficient diuretic. So we use it for only small group of edema when there is less collection of fluid. And as a result, but one thing is important, that the spironolactone can also preserve potassium because it is also potassium sparing diuretic. It don't let the potassium go into the urine like the amylolide. Right? Is that clear?
Yes, sir.
Okay. Now going to the number 5, the last diuretic. Okay, let me know if it's confusing for you. Huh? The number 5 is osmotic diuretics. Osmotic diuretics. For example, mannitol. In every cases of cerebral edema, whenever there is any road traffic accidents, okay, so let's say this is the brain and there is bleeding. So if there is bleeding here, what will happen? When there is bleeding here, so there will be this volume is increased because there's bleeding, blood has gone out of the vessel, so the volume has increased. So we call it the cerebral edema. Cerebral edema. So any accident cases, when there is head injury cases, there is cerebral edema. So because of the bleeding, because brain can't expand beyond a capacity because there is a bone outside, there is a cranium, it's a limited space, brain cannot expand. So when it cannot expand, what will happen? Because there is a bleeding, so it is taking some space. So as a result, we call this the pressure inside. So it will give a rebound pressure. We call it the intracranial pressure. Intracranial pressure will be increased. Intracranial pressure will be increased, right? Because brain cannot expand. It cannot expand. Now, brain has a limited. Now, bleeding blood is taking some space. So it has to enlarge somewhere. So if you take this much of space, it has to need to produce some space to compensate for this space taken. But brain cannot expand. Brain is totally tight by the cranium. Now what will it be? It will be a reverse pressure, right? We call this intracranial pressure. So when you are giving reverse pressure, so you can see these blood vessels are in the brain. What will happen to this blood vessel? They will be compressed. So this pressure, because of the compression from outside, intracranial pressure, the other normal blood vessels, they will be narrowed, right? They will be narrowed, which we call intracranial pressure. So if there is intracranial pressure, there is high chance of going to coma because the whole thing is, blood is the coma or death because the blood vessels have been compressed from the surrounding pressure. Do you understand this? So in every head injury cases or cerebral edema cases, meningitis cases, we have to reduce this edema, this intracranial pressure. So you will see, when you go for intern, you will see that every injury patient, head injury patient, they are given mannitol. So mannitol is an osmotic diuretic. It don't block any channel. It is just present all over. If you give mannitol, okay, by IV, we give mannitol, a small bottle, 100 ml of mannitol, we give directly by intravenous fluid. So from the blood vessel, so mannitol will be filtered. So it will just go in the fluid. It will just go in the fluid. But mannitol is very high osmotic particle. It is highly osmotic. It is a high osmolarity. So as a result, when mannitol will pass, it will increase. There will be lot and lot of water secretion into the tubule. Water will be pulled into the tubule because mannitol is a highly osmotic particle. Like what I am saying here. So this is the mannitol. If you have mannitol here and this is water, so once you put close, then water will be shifted here. Water will shift here because the mannitol can pull. It is osmotic. That's why you call osmotic diuretic. So when you give mannitol diuretic, it will automatically increase the urine volume. Okay, so but the main side effect is that mannitol is present in the blood also. So if mannitol is present in the vessels, there will be also chance of a high intravascular volume because it is also pulling the fluid from interstitial space. That is the side effect. So we use it very cautiously so that it don't increase the blood pressure ultimately. Okay, we use it when it's needed. We cannot use it any type of edema. Okay, we use it only for this type of cerebral edemas when we need to decrease the intracranial pressure. But if you use it again and again for 5 days, 7 days, 10 days, then high chance that there will be high blood pressure. So you have to constantly monitor the blood pressure when you give mannitol because it is an osmotic diuretic. It can pull the fluid, whether this is a tube or blood vessels. If it is present, it will pull the fluid from surroundings. So that is about the diuretics.